dose, because the question is, are we seeing different dose response curves for different parts of the respiratory tract? But primarily today, I'm going to talk about the exposure part of this, the transmission exposure assessment. And going forward, we would have iterative fashion, more research, more guidance for risk management. And the next slide, I present the 3 lines of evidence that occurred to my mind as we watched the rapidly evolving topics in March. At that time, when we first started writing this paper, the word aerosol had not been mentioned. So we turned to what prompted this focus. And early on, we had case reports. So that's one line of evidence that people who were not sneezing and coughing, prevalent symptoms, were capable of transmitting the disease. Next, we had limited empirical data, but very limited, and finally a line of evidence we could glean from the broader literature. So in the next slide, I look at the case reports, and case reports are exactly that. They are hypothesis forming. So in early March, we saw a number of case reports primarily coming from China and Asia, and I mentioned the studies here. I'm not going through them this morning, but you can find them in our paper. But convincing evidence that we had to focus on this potential transmission route. Then in the US, other case studies, and in our paper we say this is not an exhaustive list, but a list by example. But one of the impressive incidents focused on a choir rehearsing in the state of Washington, where 53 of the 61 members of this chorale reported illness after a 2.5-hour practice session in which they reported they maintained social distance, no one was symptomatic, and they didn't touch. So what can cause this transmission? Other examples emerged, another in a ski group that convened annually in Ketchum, Idaho this year. And again, 700 younger people, healthy, reported, and within weeks, over 100 reported positive signals and 2 died. This is a lively debate. This week, on Monday, Dr. Van Kerkhove said asymptomatic transmission is not important, World Health Organization. On Tuesday, the World Health Organization backstepped and said it is important. Dr. Van Kerkhove and Dr. Ryan reported that maybe up to 40% of cases could be transmitted. And then a study on June 4th from the Scripps Institute concluded about 35 to 45% of transmissions are from people without symptoms. Then we see an interesting debate around semantics, but I think asymptomatic to me is exactly what the dictionary says. It's people without symptoms at the moment. They may later develop symptoms, but it doesn't matter. We're talking about people without the prevalent symptoms of coughing, sneezing, fever. I think another part of this debate is because data are difficult. We don't have a good denominator. We don't have whole populations where we have adequate data, and it's too difficult to get. Probably never will have it. On all the people tested of that group, how many are asymptomatic and could have transmitted the disease? On the next slide, we turn to the literature, which is heavily dominated by an engineering community dealing with aerosols. And we find a dichotomy of particle size, aerosol size, and what has guided infectious disease models rest heavily on a 1930s model from Wells that deals with the larger aerosols, 10 microns, probably 20 microns and greater, that don't travel very far and settle easily. Particles, aerosols smaller than that, 10 microns, 5 microns, can travel with the wind. They can move greater distances. We also find in this literature that droplets less than 5 microns are associated with normal breathing and talking, and some typical light coughing that we all have from time to time. But there's good agreement across the studies that very small aerosols, less than 1 micron, about 80 to 90% of the aerosols, are contributed from just normal breathing and talking. And then in another recent study, we see the effects of wind and turbulence and humidity and temperature. In the next slide, applying this knowledge that we have so far, we turn to the literature and ask, well, what do we really know about SARS-CoV-2 and CoV-1 as their close cousin? Very little. Very surprisingly, little information has been published. There are 4 studies we found. SARS-CoV-2 was found in rooms reportedly with non-coughing patients in hallways, suggesting aerosol transmission. SARS-CoV-2 was reported in a Wuhan hospital outside of areas where medical personnel removed clothing. It was found in outdoor areas of hospital interest and in front of department store. And SARS-CoV-1 was identified in an infected patient on a lower floor, and individuals on upper floors were infected, implying aerosol transmission. On the next slide, the final study that we found is very limited. It's a 2-page study published this spring that reports in very small sample size that viruses can remain viable and infectious in aerosols for hours. And the half-life of the CoV-2 and CoV-1 were similar. The National Academy of Sciences, a standing committee, reported on April 1st in reply to OSTP, Office of Science and Technology Policy in the White House, that while the SARS-CoV-2 specific research is limited, the results of the available studies are consistent with aerosolization of virus from normal breathing. I was struck by the fact that this evidence didn't prompt more research or more research recommendations. So in the next slide, I turn to the broader literature. Next slide, please. We conclude from the case reports, the limited evidence we have, and I think we skipped the broader literature slide if you go back one. Does the literature inform aerosol transmission? And we have 4 summary points here. Aerosol transmission for infectious agents is well accepted, with examples tuberculosis, measles, chickenpox. Second, SARS-CoV-1 particles less than 3 microns remain suspended almost indefinitely and can travel. Lipid envelope viruses, which SARS-CoV-2 is, and also human coronaviruses, measles, and general chickenpox, are very sensitive to temperature and humidity and have better survivability at lower temperatures, humidity, less so at higher temperatures. Some studies suggesting they don't survive well at humidity greater than 50% or temperatures greater than 77 degrees Fahrenheit. And small droplets are confirmed in the literature as penetrating to the alveolar region, where they can be potentially more infectious. So in conclusion, next slide. Current evidence does point to aerosol transmission. And in the absence of coughing and sneezing, the evidence does point to breathing, talking transmission of aerosols, presenting challenges for reopening and potential reemergence, and needs to address aerosol transmission. And looking at this weight of evidence, which is limited, but there are suggestions that masks to protect oneself, not just to protect from sneezing and coughing to infect others, could be very helpful. And then the role of building contamination and building controls arises as a focus. So finally, in our paper, we recommend the next slide, research areas characterize SARS-CoV-2. This isn't rocket science. We need to know survival, concentration, duration, transport. Or more difficult, characterize the effective dose to different parts of the respiratory tract to get a better handle on disease progression and severity. Why in some people is this so deadly and others not so? Is their role being played by aerosols? Third, evaluate aerosol contamination in building with a view toward refining their guidance regarding clean building, ventilation, filtration, temperature, humidity controls, and so forth. And finally, looking at the role of human activities in transmission, both in enclosed and open spaces, GEMS, vigorous breathing and quiet. I have one final slide to share that demonstrates the, if we go back to our research, feeding risk assessment exercise, very lively. 5 papers I mentioned briefly. The New York Times reported, these are within the last week or 10 days. The New York Times reported that 37% of national fatalities are residents of long-term care facilities. In 15 states, that number rises to 50%. But a contrast in the article is between the parts of those, the kinds of facilities that have 100 beds along corridors in nursing homes versus a campus-style model where a study of 245 campus-style homes to over 2,000 residents found only 9 cases and 6 deaths. The second study is the first one I've seen on studying commonalities of COVID-19 epicenters and comparing nursing homes, cruise ships, and prisons. The third one studies 166 studies and finds inverse correlation between COVID occurrence and death and temperature and humidity, which affirms what we found earlier implied in the literature. And finally, the last 2 of the studies I mentioned earlier just this week, the 2 statements made by the WHO based on their research and the study of 16 international groups reported in the Annals of Internal Medicine by the Scripps Institute group. So I leave you on aerosols at this point on the edge of your chairs waiting for the next study and for Dr. Haas.
Thank you, Betty. And I want to remind everyone, if you have questions, please put them in the question box and I will collate once both speakers have gone, then we will have a chance to ask questions to both speakers and they can both respond to questions. So Chuck, go ahead.
Chuck, I'm going to go ahead and give you the screen here. Just 1 second.
Okay.
There you go.
Very good. Well, thank you again for attending. So I will, can you see my screen, Seth?
Yes.
Okay. So I will carry forward from what Betty talked about and give you my perspective of a number of factors that I think SRA members would be interested in pertaining to the issues of COVID-19. So Betty already shared with you the traditional risk analysis framework that we use. I'll just make one additional comment for a transmissible disease like COVID-19. At least my typical thought pattern is to incorporate transmission models within the risk characterization step. And we know how to do that, and we have experience doing that in the framework of quantitative microbial risk assessment. So dealing with transmissible agents is not something new to our practice. So I want to start out by pointing out that we in fact do have dose response models that could potentially bracket dose response data for SARS-CoV-2. About 10 years ago, I had a visiting scientist in my lab, and we reviewed the literature on coronaviruses for data that could be used to inform a dose response model. And we developed 2 relationships. One relationship in the blue line based on pooled data for various mouse coronaviruses, and the upper red line for human coronavirus 229E, which was actually a human volunteer study. So I want to make 2 points from this dose response curve. As we've observed for many microorganisms before, there is no value of average inhaled dose or average exposure concentration at which the risk goes to 0. And we do appear to have a low dose linearity situation, as we've seen for other infectious agents. And the dose for 50% infections based on the human trial data is about 10 inhaled organisms. For the pooled mouse data, it's about 400. So there's a range of 40-fold or so between the two viruses. And we do need data on SARS-CoV-2 to understand where perhaps within this range or outside the range the infectiousness is likely to occur. So the reason for including the term Swiss cheese in my title is from a risk management point of view. For any infectious agent in any scenario, we're really used to controlling the level of risk by placing multiple barriers in place, each of which might be imperfect, but in combination, just as if you had slices of Swiss cheese and misaligned the holes, each barrier would have certain holes, but the misalignment would mean that one or more barriers would likely trap a high degree of the challenges that might occur. So we don't need a perfect barrier at any stage. The perfect is the enemy of the good. We just need multiple barriers along the line that may act by different mechanisms or with different dynamics to keep risk down to a level of control. And indeed, we don't need total control of the entire set of challenges if we remember that our real goal is to drop the reproduction number, the R0, from a value of 3 to 4 down to below 1. A 75 or 80% aggregate efficiency of all the barriers that we look at would suffice to bring the outbreak under control. The right-hand graphic is from a paper by Science. Betty talked about a paper out of the Scripps group. This is from the Scripps paper. And the idea is that masks for both the infected asymptomatic individual and healthy individuals both act to reduce exposure. And it's wearing by both the source of infectious particles as well as potential recipients that results in greatest reduction of exposure. And in fact, I think the mask issue is going to represent a case study in poor risk communication. And I don't have time to elaborate on this, but the messaging still in many parts is that masks by users protect the population affected. So the aim is to convey a message of altruism. And I think the public health folks have fallen down on the opportunity to also say that they also protect you. So you're not doing mask wearing for the other, but also doing it for yourself. The issue of physical distancing between people is also controversial. And as Betty said, the 6-foot distance arises from very, very early studies, which are really only based on the fact that in quiescent conditions, larger particles will in fact drop off in a very short distance away from the source. But those other studies really ignore a couple of other factors. First of all, that infectious organisms can be conveyed within smaller particles. They may travel further. And second of all, that the velocity with which they're emitted by coughing and sneezing, even for large droplets, may cause them to project well beyond 6 meters. And there have been some very elegant photographic studies that demonstrate this. that have been published. And what's interesting about the 6-foot message is if you compare messaging in different countries, in countries on SI, on metric systems, the messaging is often either 1 meter or 2 meters. And they interpret those early imperfect data very, very differently. So there's work to be done by our risk communication folks with an SRA to understand the conveyance of those messaging memes. So in order to control COVID-19, we really need to look at a hierarchy of controls. And this is sort of a typical inverted pyramid that in other contexts we're used to. I started out doing work on hazardous waste way back in the ancient days, and some version of the pyramid on the right was often used to describe controlling hazardous waste exposure. It works well in controlling infectious agent exposure, with the preferred actions being at the very, very top of that inverted pyramid, but we really need all slices of the pyramid to give effective multi-barrier control, the slices in my Swiss cheese model, as I noted earlier. The last thing I'll leave you with is I think there's an interesting case study on dispute and way of knowing and making inferences from data. And I've seen this before in the microbiological risk area, and it's coming to fore again. People from a medical and public health background very often look to epidemiology as a gold standard in making inference, but epidemiology is a very, very crude tool for detecting small differences in improvement. Obviously, in SRA, we're much more used to a risk analysis approach, and I think the two ways of knowing and making inference from knowledge need to be combined and brought to bear by the national and international authorities in terms of coping with the current pandemic. So with that, that's my last slide, and I'll be glad to turn it over to Seth for Q&A, and we can end sharing. Thank you.
All right, thank you both very much. And again, a reminder to those listening in, please type your questions in the question box. We don't have much in there yet, but please get those questions coming in. So I'll start off then with a general question to both of you. So we hear an emphasis right now on masks and on social distancing. How much is known about how effective those masks are if someone's infected at protecting others and at protecting that individual, and how much does it matter what type of mask it is?
So this goes back to ways of knowing and ways of interpreting the data. So the medical and public health communities are focused on epidemiological evidence for mask wearing. And the epidemiological evidence has been mixed, although there's been some very nice meta-analysis published recently by an SRA member from Australia, Raina McIntyre, who has looked at evidence in healthcare workers primarily, and there is reasonable evidence that wearing masks, even cloth masks, are good at protecting healthcare workers from infection. That's really the only type of evidence that many in the healthcare community and public health community regard as significant. However, there have been a number of studies now in the laboratory with cloth materials and surgical mask material, challenging them to airborne particles of different size ranges. And the materials themselves, even when they have gaps, can show 50, 60, 70% removal with cloth mask material of those particles, which if we keep our eyes on the goal of reducing R0 from 3 or 4 down to an R0 of 1 or less, could be important in preventing transmission, both if worn by a asymptomatic individual as well as a potential receiver. And let me just say one more thing about the word asymptomatic, which Betty got to, and I think needs a lot more emphasis. So there's a miscommunication with the lay public on the terms of asymptomatic, and the WHO farce of the past week showed it. So if you pick up a dictionary, asymptomatic refers to current status of not having symptoms. But many in the medical community have been using the term asymptomatic to refer to individuals who will never show symptoms in the course of disease. And I think the medical community have failed to appreciate the difference in the lay use of the term from the medical use of the term, which has caused some of the latest confusion.
And Seth, just to add a note to what Chuck has said, I was looking for mask efficiency when in March I was very much concluding that masks could be effective. And there was then a debate and not enough masks for medical personnel, so you can't tell everybody to wear them. And I found some evidence that cloth masks, particularly when lined with silk now, I don't have the site in mind, but could be quite effective.
Yep.
And that to the N95 mask, although very efficient, not really necessary. But I was looking for more study of this because I thought, practically speaking, sometimes the simplest things that can be done effectively in a fairly short period of time are not done. So I think this is an area for further definition, because if we just simply knew the effectiveness of different kinds of masks, for sure, but right now I've found enough evidence to think that we're certainly in Chuck's Swiss cheese model creating masks.
Okay, and then I had a follow-up to this. This is from Felicia Wu. Is there any evidence that SARS-CoV-2 can infect through the eyes?
So there have been a couple of case studies, actually including one of the very early fatalities in Wuhan of an ophthalmologist who had a fatal case due to an apparent eye infection. There's a suspect case study actually from a commentator on NBC who believes he contracted CoV-2 from droplets on an airplane ride that he was taking. There's physiological connection via the tear ducts, but there haven't been, as far as I know, any animal studies or any human studies that directly support that route. But I think it's potentially highly important.
Okay, we have a series of questions here related now, in a sense, to airflow in buildings in light of aerosolization and other issues. So I'm going to ask a couple kind of together here. The first, should we set air conditioning temperatures at a higher temperature, say 77, given that the virus has a harder time surviving at higher temperatures? And kind of along with that, what about this idea of saying, let's move entirely from recirculation to 100% outdoor air into a building, essentially pressurizing outward?
Well, in the work we've done so far, and we combed the literature and we watched everything being published to try to respond. And I also had my background in looking at buildings after 9/11. So this whole idea of building contamination and transmission of infectious disease and contaminants is well known. There's a large database. I found very little about these epicenters, and that's why we called for focus, go into buildings where we've had epicenters. If we tell people to go shelter in place and we're telling them to go to buildings that are not healthy, we're not doing them a favor. I think we could learn a lot more from focusing on buildings where epicenters have occurred. And this is something we called for. This is a tough question to answer, but I think in general, we probably know enough to say now that perhaps all the evidence we have does point to greater ventilation, higher humidity and somewhat higher temperatures being more effective. This latest study that just came out that did focus on 166 country study that was published very recently. It's reference 3 on my last slide. Does show a convincing, and I have not critiqued the study, but it's published in a peer-reviewed journal, does present a convincing case that occurrence and deaths are inversely correlated with temperature and humidity. So on that basis, if I didn't know any more, I would ventilate my buildings, raise the humidity, and raise the temperature somewhat.
I mean, I agree. And the other thing I would point out is there are active ways to clean up indoor air beyond just ventilation. Installation of HEPA filters, upper level UV radiation, and active internal air conditioning with filtration will be used.
Okay. Thank you. Another question, a little bit different, but given recent WHO and other missteps in public health communication, what are reliable resources that we can turn to, particularly on aerosol transmission? And is there a role for SRA in this regard? I'm going to let both of you answer, and then I'm going to jump in with something we've been doing with SRA.
I think, go ahead, Betty.
It doesn't matter.
I certainly think there should be, because a lot of the issues pertain to exposure assessment, and we certainly have very active exposure analysis groups within SRA. I know some of the active researchers in the area are SRA members or members of allied societies, whether it be CTAC or the Society for Exposure Analysis and Epidemiology. So I think there very well could be a role for SRA. And obviously the risk communication area, which is really badly mangled by both WHO and CDC, really needs to point a better direction for how to communicate to the public.
As I said in the beginning, I think all too often in the face of a pandemic and in this circumstance, we turn to one discipline, infectious disease specialists. And when I tried to answer questions in my own mind about this aerosol observation raised by these transmission issues, I found it is so interdisciplinary. We need interdisciplinary focus and interdisciplinary guided research to really clarify a number of these issues. And some of it is research at the 101 level. If it's organized, we could get some really timely and effective answers to contribute as science, hopefully science marches forward, iterative way risk analysis and then better decisions can have a basis for guiding our policies. So I do think either SRA members or the thinking of this society can inform methods to go forward to organize all of the work being done and not just from one discipline or one set of grassroots that attempt to answer these questions.
Thank you both. And I would also like to point out we have a website, sra.org/COVID-19-resources. I put it in the chat bar as well. And we are collecting resources on things related to COVID from a risk analysis perspective. All these episodes of this podcast and webinar are on there, and additional material. If you have suggestions for more reliable peer-reviewed information that we can put there, send it to, I guess, me, and we will work on it. Okay, so another question. This one's a little bit different, but there's emerging evidence that COVID-19 keeps mutating in different parts of, or different regions of the world. How does this impact dose response assessments? And can we combine across these different parts of the world if it's mutating?
So all microorganisms mutate. The real question is whether or not any of those mutations confer different physiological properties or potencies. And so far, the evidence seems to be no. The mutations are there. They serve as potentially good fingerprints for understanding the time course and the transmission and where particular inoculating events may have come from. But there's no evidence of a shift in potency that has arisen. Certainly, if one does arise, then that would need to be factored into a dose response analysis.
Okay. Another question. It is important to consider the broad basis of knowledge about airborne particles like PM2.5 and where they, I'm summarizing here a little bit, where they deposit nasal cavity, pharynx, pulmonary region. Coronavirus can cause effects in all of these regions. I'm going to summarize here. How much do we know about that, and how important is where it deposits? I think that's kind of the question.
Well, that's something that I tried to present in our paper. We looked for the evidence in general for other infectious agents. And I summarized in my remarks that we found evidence that infectious agents can have differing potencies depending on where they're deposited in the respiratory tract. So we know that. What we don't know is very much about COVID-19 and the SARS-CoV-2 deposits, because it's not been studied and characterized. So we can only kind of infer from the other evidence that we have of infectious agents. But Chuck, perhaps you have more direct evidence, but we looked at animal.
The dose response relationships we have are all for inhaled dose, which would be deposition in the lower respiratory tract. There are no data for the larger particles that may deposit in the upper respiratory tract. Certainly we know that's a route of infection, but in terms of what difference they might have on potency, I don't think we know.
Okay, thank you both. Oh, sorry, go ahead, Betty.
From the literature I found interesting is that in some instances of infection, the body's defenses may have more time to react with something that's a severe acute respiratory agent. If the agent is only deposited in the upper part of the respiratory tract. That's only inferred from what we know about other agents. It's certainly not confirmed for this particular coronavirus.
Okay, thank you. Now I'm going to combine a couple questions here. This comes back to the idea of social distancing. And I'll summarize. And is 6 feet really sufficient, or should we be doing further? And then very specifically, for those of us who are faculty members or students, are there ways we can minimize the aerosol transmission risk on college campuses that are going to open in person this fall?
Well,
So
go ahead, Chuck.
go, Betty. Go.
Okay. I think I already said in my conclusions and the call for research that, in a way, what we've been doing is just blunt instruments, 6 feet, and don't touch and surfaces. And we've seen backing away from the importance of surface contributions. But as we refine our knowledge, I think we can be much more specific. And if you turn back to my recommendations for research, the more we know and the more specificity of information we can convey to the public, the more the publics will understand what to do and not to do on their own. So I think we do know enough now to say that mask wearing to protect oneself and others is important. That's not something that we said so clearly before necessarily, or back in March. So we know that. We tend to know now that distancing, fresh air, being outside, riding bicycles at a distance is very different from working in a cold gym that's air conditioned without airflow. I think we know that. So I think we know a lot, and in our paper we just tried to describe what's known and not known, and certainly not to overinterpret what we have as real evidence. But I think we know enough now to have vectors point in directions of ventilation, temperature control, mass wearing, and certainly looking at buildings to see if we find commonalities that indicate transmission within the buildings and deposit that should be cleaned up and should be controlled by ventilation and other measures.
And I think getting to the particular case of universities, and I've been involved in some committees here at Drexel looking at what we do in the fall. You know, a lot of universities have old buildings with ventilation that hasn't been well characterized and that was never really designed for getting high levels of indoor air quality, but mainly getting energy efficiency, if that. And I think all those buildings need to be looked at in terms of what we do to maximize indoor air quality, whether that's outdoor air ventilation or other more active strategies, as well as physical distancing. It will be a combination of things.
Okay, thank you. Okay, so now we get a more specific question here. We need to, or comment really, we need to remember the deposition and early clearance is determined by the aerodynamic size of the particle and mixed composition, typically containing a small amount of infectious material. So it basically depends on more than virus size. How much is known about that?
Chuck, do you want to take that one?
Okay. Well, I mean, the viruses are within typically fluid that's expelled from the nose or the mouth. And so that to some degree protects the virus from desiccation and inactivation as it traverses the space between the source and the receptor. So we know that it's not a 50, 100 nanometer particle that we're concerned with, but it's a micron sized particle. You know, I suspect what's behind the question is also if there are other particles in the atmosphere that may attach themselves to these virus-laden particles, could they have an effect? And that's a good question. We don't know a lot about the interaction between, let's say, PM 2.5 and bioaerosols, so there is some suggestive evidence that relates to susceptible subpopulations, potentially that could be an interactive effect that we need to pay more attention to.
Eddie, anything else to add to that?
I think no, I think I'll leave it at that.
Okay. So this goes back to that 166 country study. How big was the effect of temperature and humidity? And would small changes on indoor temperature and humidity matter, or is this a larger scale effect?
I give the reference to the study. It was just published, and as I said, it was published in a peer-reviewed journal. I did not attempt to critique it, but it found a consistent inverse correlation of COVID occurrence and deaths with temperature and humidity. And it was consistent with the other literature, so I grabbed the study. I do have it. I have given the reference here. Beyond that, I'm not prepared to critique the study at this point beyond what the authors actually present.
I mean, I've looked at it a bit.
Have you?
I would be careful about over-interpreting it because they're using outdoor temperature and humidity to infer an effect. And we know that most of the transmission appears to occur in indoors, and therefore the outdoor temperature and humidity may not necessarily be a good proxy for what happens when the transmission occurs. And in fact, I think we're seeing a real life example of that right now with the case counts mounting in Arizona. It's obviously quite hot in Arizona, although not necessarily that humid, but people spend most of their day indoors. And so what the outdoor meteorological conditions mean with respect to indoor conditions where transmission occurs is really uncertain.
Yeah, and to add to that, and I agree with that completely, I have long thought when our paper calls for research of buildings and looking at epicenters and looking at what they share in common characteristics, I am convinced, or reasonably convinced, that there's at least a hypothesis that colder, air-conditioned, small areas with linking ductwork and airflows could well, I think we know enough to say those could well, it's a hypothesis at this point, but those could well contribute. And if I think of someone exercising, say, in a small gym space, adding to that from Chuck's Swiss cheese model, we add layer on top of layer, compounding what we know so far. So they're exercising, breathing deeply. So now they're in an enclosed small space. That's not going to relate to outside air, but I think we know enough to become very suspicious of those environments. And that's why this just first study that's attempting to look at commonalities across epicenters, nursing homes, cruise ships, prisons, and so forth, I think is very important to follow up on and try to understand, because understanding these factors could lead to very specific guidance and improvements in public health.
Okay, now switching back to looking at risk analysis of profession and how we can help here. And this goes back, I think it was to some comments that Chuck was making. Epidemiology is giving a huge weight. How should risk analysis and risk analysts better translate what we do to help with risk management? Basically, what can we do as a profession to try to provide information in a more understandable, useful way?
I want to toss this first to Betty to get her reaction, because my gut sense is what's happened here on the infectious disease side is perhaps analogous to what happened in the 80s with respect to the tension between toxicologists and risk scientists. Without seeing the bodies from a chemical or physical insult, how you could determine whether something is a problem. And I think we're seeing a similar debate playing out with respect to infectious disease.
Yeah, I think you're absolutely right. And that's why I called my helmet to be or not to be, because before risk analysis was introduced in 1976, we saw a lot of soliloquy. Is it or is it not, based on epidemiology? And when we didn't have those studies, pathology. Did we see cancer or not?
Right.
It's not the right question, and it's not the right dialogue. The right dialogue is my Broadway show analogy. We need lighting specialists and costumes and playwrights and directors, and we need a lot of information to weight it all. And as we all know, epidemiology is extremely important, but rarely available. Databases are just simply not that detailed to make the answers clarify themselves through epidemiology alone investigation. So we have to be careful not to do soliloquies. And I think risk analysis tells us this by its very nature and instinct. And we created it. We created it to answer the very question Chuck has just raised. What do we do when we have information from toxicology, in vivo and vitro studies of different types and weights and different species? And how do we put this all together to make sense of what we know and then move forward to organize it, turning it over to then risk managers and to the publics to understand? So it's not easy. thinking of it as a Broadway show is, I think, a good way for us to approach it. And so epidemiology is important. Infectious disease epidemiology is certainly very important, but it's not the whole show.
Agreed.
Okay, so we are nearing the end of our time. I'm going to close with kind of one question that sort of underlies a little bit of what a few people have asked. But if you could convey one thing to individuals, or a few things, maybe not just one, but what would you suggest individuals do if they're concerned about transmission and what they can do to reduce it personally? And then you can add any other closing comments you want as well.
Betty?
Yeah. Stay healthy. Be sure you're outdoors as much as possible. Ventilate your homes. Wear a mask when you're in close quarters. And don't overly stress about things that are just not that important. When you're riding a bicycle in a big park, is far less important. And weigh the evidence we have in your own mind. The publics are very smart, and the evidence is sometimes not as organized as it should be. But try to think about what evidence is there and make your own conclusions. But I think at this point, mask wearing in crowded environments is clear, and be careful of buildings and pay attention to factors that can make buildings better spaces to work in. Agreed.
That's a good way to end.
All right. I want to thank you both again for taking time to do this. I know you have a lot going on with COVID and everything else going on. So thank you both. And for everyone else, this will be available in the next few days. We posted on YouTube. The link will be on the webpage. And next week, tune in. We have a podcast focused more on the risk communication side of this. So thank you, Chuck and Betty.
Thank you.
Thank you.